Ευχαριστούμε και εμείς τον κύριο Ανδρέα Ξανθό, αναπληρωτή Υπουργό Υγείας, που περιέγραψε σε ένα σημαντικό βαθμό, νομίζω, και την κατάσταση που υπάρχει σήμερα στην ψυχική υγεία στη χώρα μας και έδωσε και ορισμένα συγκεκριμένα στοιχεία και από δουλειές και έρευνες που έχουν γίνει σε αυτό το χώρο, καθώς και τις βασικές γραμμές των πολιτικών που θα αναπτύξει το Υπουργείο Υγείας σε αυτό το τομέα. Και θέλω εδώ να πω ότι, αν μου επιτρέπετε, ότι από αυτά τα οποία ακούσαμε, ξεχωρίζω και το κομμάτι του κοινοτικού προσανατολισμού στην ψυχική υγεία, που είναι ενσωματωμένο στη φιλοσοφία της ψυχιατρικής μεταρρύθμισης. Με συγχωρείτε. Και βεβαίως τη συνέχεια στη φροντίδα του ασθενούς, που είναι το μεγάλο ζητούμενο, μέσα και από τη διαδικασία της τομεοποίησης. Και νομίζω ότι ένα σημαντικό στοιχείο, το οποίο ακούσαμε σήμερα, είναι αυτό του να αποκτήσουν οι τομείς αποφασιστικές αρμοδιότητες. Αυτό είναι κρίσιμο στοιχείο για όσους έχουμε δουλέψει σε αυτό το χώρο, και βλέπω εδώ αρκετούς συναδέλφους και συναδέλφισες που έχουν για πολλά χρόνια δουλέψει πάνω σε αυτά τα πεδία, και βεβαίως και από ό,τι κατάλαβα, και την προαναγγελία ορισμένων νομοθετικών πρωτοβουλειών για θεσμικές αλλαγές, τόσο στο επίπεδο του πεδίου των εισαγγελικών παραγγελιών και των ακούσεων νοσηλειών, όσο και σε άλλα πεδία. Γνωρίζω ότι το Υπουργείο ετοιμάζεται για αυτές τις αλλαγές, και νομίζω ότι μπορεί πράγματι να είναι προς τη σωστή κατεύθυνση και να βοηθήσουν αυτό το τόσο κρίσιμο τομέα που ειδικά τα τελευταία χρόνια έχει υποφέρει, και έχουν υποφέρει και οι δομές ψυχικής υγείας από αυτή την πίεση που θα έλεγα ότι συνεχίζει βεβαίως να υπάρχει, γιατί τα προβλήματα δεν τελειώνουν με μια αλλαγή στο κυβερνητικό επίπεδο. Συνεχίζουν να υπάρχουν και έχουμε μπροστά μας πάρα πολύ δρόμο προκειμένου να επιχειρήσουμε να αλλάξουμε σε αυτές τις κατευθύνσεις που ακούσαμε. Dear colleagues and dear friends, it is a great honor to welcome Mrs. Francesca Colombo to the podium. Mrs. Colombo is the head of the Organization for Economic Cooperation and Development in the Health Division, and her work throughout the years, among others, has assisted in supporting the strategic orientation of the General Secretary and their implementation in the area of health. Mrs. Colombo is here today to present to us a very important issue entitled Making Mental Health Count, the social and economic costs of neglecting mental health care. Mrs. Colombo, welcome.
Well, ladies and gentlemen, dear ministers, thank you. It's really my great honor to be here today to speak about what I think is one of the critical topical issues in healthcare today, which is mental health. Let me go back because it's going too fast. What I would like to speak today is about the fact that mental health is really pretty much neglected, and neglected issues. It's not given enough attention, the political attentions, but also the economic attentions it deserves. And I would like to do so focusing not just on Greece, but giving you a little bit of an overview of what happens across OECD countries. I will be doing three main things. I will start with some key facts and figures. I will then say a few positive things about what is happening recently in mental health, and also some negative things that are not working as well as one would wish. I will then give you some figures for Greece, noting, however, that there are very few data that are available internationally on Greece. And I will conclude as forth with some messages about what, from our perspective, should be done to making mental health count better in Greece as well as in other countries. So let me start with some facts and some statistics which are probably quite known to you, but I think they really give an idea of how dramatic the situation is. We know that across OECD countries, some 20%, or say differently, 1 in 5 adults, people suffer from a mental health disorder, whether it's a severe mental health disorder, which affects about 1/4 of these people, or more often, some mild or moderate mental health disorders. So 1 in 5 persons across the OECD countries in the adult population. This is not to speak about the children, or also about the elderly, because mental health is also a particularly difficult issue for these population groups. And particularly for children, we know that the first time for the onset, the initial onset of the mental illness is very early in life, sometimes like 15 years. Most of the people who have developed a mental illness do have already some symptoms as early as that. But if we look over the life course, the situation is even more difficult and more perhaps black. We know that over the course of one person's life, 1 in 2 experience some phenomenon of mental health, some instance of mental illness. Very often it's depression or anxiety, some mild to moderate disorders. It is still quite striking. It means that in this audience, about your neighbor, the person that you look on your left or on your right, might develop at some point in their life some mental illness. And we know that mental illness has quite significant negative consequences in terms of health, of course. People with severe mental illness across the OECD countries live some 20 years less. They die 20 years earlier for different reasons. Partly is because they commit suicides, but not just that. A number of these people do develop physical illnesses as well, which are not treated properly. For example, they might have heart attacks or cardiovascular disease or diabetes or cancer, and very often they might even be the consequences of aggressive drug treatments which have not been appropriately given. So the situation is not really a particularly bright one across OECD countries. This is a significant cost for economies. If we put together the estimated direct costs, so the cost for health services, as well as the indirect costs, which are the costs in terms of lost productivity or the onset of disability and sickness, absences and things like that, if we put together both the direct and indirect costs of mental illness, they account for something like 4% of GDP across OECD countries. And this is really a particularly high number. We know that in the health system, the amount of resources which are devoted to mental illness is actually quite low. If we think that across the OECD countries, the budget which is devoted to mental health is usually between 4 and 15% of total health expenditure, knowing, however, that the prevalence of mental illness is about 1 in 5, it's about 20%, we could say that there is an underinvestment in mental health services relative to other services in health systems. And to give you some additional facts, as I said, the cost of mental illness is not just for the health sector itself, but it's really about the economies at large. People with a mental health disorder are really less effective at work. Even those with mild to moderate disorders, some 70%, so 7 in 10, are less productive, less effective at work. But very often they're also more likely to be away, absent from work. For people who have mild to moderate disorders, 2 out of 5 people had been absent from work in the past week, so in the past months, or in the past 4 weeks. And this becomes 1 in 2 for the people with severe mental health disorder. And if we look at the rates of employment of people with mental illness, the situation is again quite bleak. For those who have mild to moderate disorders, they're 2 to 3 times more likely to be unemployed, but the situation is much worse, 7 to 8 times more likely to be unemployed for people with severe mental health disorder. So this is just to give you some facts. OECD is quite known for the statistics. We're trying to collect some of the facts that exist, knowing, however, that there are unfortunately very few statistics in this area, and that's probably an area that will need to be improved into the future. So let me say about a few words about what has happened in mental health systems across OECD countries, and I will be saying some positive things and some negative things. So let me start with 3 positive things. Suicide rates have been generally falling, and these I'm looking not specifically as yet, I will show later about the recent years of the crisis, but in the past 2 decades, suicide rates have been falling in a majority of OECD countries. The countries which are really on the left show a decrease in suicide rates. We see, unfortunately, that Greece is among one of the few countries where suicide rates have increased even before the crisis took place. Now, for Greece, it's interesting to know that the starting point is from very, very low rates of declared suicide. So there has been an increase, but starting from low rates. But we suspect that there is a lot of underreporting, partly because of the stigma which is associated. So even for suicides, which is quite difficult to hide, we suspect that there is not as much, there has been in the past at least, not as much reporting precisely for the stigma which is associated to it. A second positive fact is the deinstitutionalization. Across all OECD countries, we see a tendency to move treatment for severe, particularly mental health disorder, away from inpatients, away from institutional settings, and more into the community. This can be seen, the blue one, it's for OECD, but I put also Greece, some slight decreases. It's a common trend that we see. Obviously, the key challenge is that it's good to move people in the community, provided there are community and primary care services which is already out there to take care of people who have these disorders. The third positive thing which I would like to highlight is the role of primary care services, so GP services. This slide is a little bit crowded, but what it shows in the blue, in the dark blue, which are the bars which are the highest, is the people with a mental health problem who see a primary care physician, so a GP. And it's the share of all the people with a mental health illness who see a GP as a first point of contact. And we see that's quite positive. We see that for people who do have a mental illness, the first point of contact does remain, for a majority of cases, for about 3/4 of the cases, remain the primary care sector. This is positive, obviously, because we know the primary care has a very significant role in terms of being the first point of contact, the point of referral, driving referral to other parts of the system, but also in utilizing things such as talking therapies that can be quite tremendous, effective, particularly for people with mild to moderate mental illness. And obviously because they have an important role at coordinating the care across the system. So this is to show some positive facts, but let me now talk and go to the but, to things which are not work as well as one would want. And the first one is around under-treatment, really. So the first cause of concern is that the many people who have a mental illness do not receive treatment, or they receive insufficient treatments. And these slides show the shares, the number, the percentage of people in specialist treatment by severity of the disorder. And we see even for the OECD average, which is on the right for about 29 countries, that with people who have a mental health disorder, very few actually, some 1 in 4 do receive the services that they need across the OECD countries. So it's close to 25% for severe disorder. And it's even much slower when we look at moderate disorder or mental disorder. So this shows that out of the people that really need the care, very few receive the care that they need. And if we look at Greece, which is about the middle of this chart, we see that the numbers are even fewer. So fewer people than the OECD average, no matter whether it's severe mental illness or moderate disorder, very few people really receive the care that they need. So this is the first cause of concern. The second negative factor or cause of concern has to do really with the coordination. Now, it's a good thing that care has moved progressively out of hospitals, out of institutional care and towards the community. However, this means there is an added need for improving the coordination of care, which has not really been always the case. There is poor coordination often within the health system, so between primary care, specialist, outpatient, and hospital cares, but also, and this is quite important when talking about mental illness, between the health sector and other sectors of the economy, whether it's the employment, education, social care, or housing. So it's really a quite important deficit in coordination. And the third negative trend I would like to highlight is really the gap in information. We are an economic organization that really collects a lot of data, and mental health within the health sector is probably the area which has the least information. There is very poor data about what works and what does not work, about quality, expenditure, and outcomes, and especially there are very few internationally comparable data. So it's very difficult to have evidence-based policy making when we are talking about very few data that exists. So let me just show a few slides about Greece before going into some suggestion for improvements, knowing again that we had some trouble to find some of the figures for Greece. First of all, although there's been a reduction in the use of institutional care, Greece remains more than other OECD countries reliant on institutional care. This is the number, for example, of psychiatric care beds per 100,000 population. Of course, the data in itself does not say what's the quality of the services, but it is to note that Greece remains above the OECD average in terms of reliance on the institutional care. Secondly, it's about really what I was highlighting as one key weaknesses of a mental health system is the lack of data. This chart shows a number of indicators. I'm not expecting you to read through these indicators, for which it's indicated whether the data are available or not for Greece. And we see that there are really quite a lot of indicators for which it's difficult to find indicators at international level. They might exist perhaps in some of the service delivery sectors here in Greece, but they don't exist at the international level. And even when we conducted the study by OECD, we really had some trouble. Greece was not able to report to OECD the indicators on mental health care, for example, and quality of health care. There are some signs of worsening mental distress, and particularly that's obviously the impact of the crisis. We know there is a strong correlation between high unemployment and the risk of mental illness, and this has been the case for Greece as much as for other countries that have been significantly affected by the crisis. Major depression has really increased by 2.5-fold times between 2008 and 2011. And funding for mental illness has been cut throughout the crisis. Obviously, there have been significant cuts in the Greece health systems across the board, but it is true that in knowing that there is an increase in the prevalence of mental illness, the cuts are something in this sector, something that make the job of people in the sector being particularly hard. Suicide rates have significantly gone up. This is a similar slide to what I showed before. The slide which I showed before looked at the past 2 decades. This looks at the past few years, so between 2006 and 2011. And it's really quite striking to see, first of all, there are much fewer countries that report a reduction in suicide rates. There is a much large number of countries that have seen an increase in suicide rates. And for Greece, it's really one of the countries which has seen one of the highest rates of increase in suicide. So what can be done? Let me conclude just by some quite simple suggestions about what, from our perspective, from SPD perspective, should be done to improve the mental health status and services for not just Greece, but OECD countries as a whole. And I will identify 4 steps. So the first one is really to measure mental illness much better. To have evidence-based policies, there needs to be much more data, much more statistics, many more data really that can guide decisions by policymakers. And this has to do for simple things, for example, even just counting, identifying the number of people with, which have mental illness. Prevalence rates are not reported by all countries. And there are a few countries that really have patients' registries, such as some of the sophisticated registries that exist in Nordic countries that permit really to have real-time information about the people with mental illness. There are obviously a significant under-reporting and poor understanding of the costs of mental illness, both in the health sector, but also quite significantly across sectors. So not just in health, but also the social care sectors and the employment sectors, and also the education, knowing that, as I said, a lot of the mental illness starts in very young age. And there is obviously a need to improve some of the quality and outcome reporting. Few countries have outcome frameworks for mental health. There are some of them that do have some of the Anglophone countries, England, New Zealand, and Australia have some wonderful outcome frameworks for mental health, but this is more the exception rather than the commonality. Secondly, it's obviously improving the services for people suffering from mental health illness, both in terms of increasing access to health services and particularly for GP, community care services for people with mental and moderate disorder. There is perhaps a need to make further use of evidence-based psychological therapies. There are a few countries that have developed in this area. The UK, for example, has increased very much in improving access to psychological therapies, but there are other countries which have done very little in this area in creating the services and in rolling out the services also across the countries. And there is an important need to strengthen the competencies of GPs, of primary care physicians. As I said in a previous slide, this is really the first point of contact, even right now, for the people with mental illness. But very often, GPs do not have the training, the competencies to even recognize an instance of mental ill. There are some countries that can be looked at for good examples. In Norway, for example, they've done really specific training dedicated to GPs for mental illness. Or even in Australia and Denmark, they are really setting up a framework for training and investment in GP competencies. The third area is to do, obviously, with severe mental illness, where there are 2 main recommendations that we have given in our work. One is to improve the coordination between different care settings and between different levels of care. There are very few countries that really use a care plan, that have a care plan which is developed, used in community, and then transferred across the different sectors. There are good examples, again, in Australia, which has implemented the so-called Better Accent initiative. This initiative really encouraged GPs and practitioners and primary care practitioners to work together with specialists in a way to improve coordination of services. But there are also the important needs of paying attention to the physical health needs of people with severe mental illness, knowing that there is a high rate of comorbidity between mental health and physical health needs. England has specifically implemented even some financial incentives for primary care physicians to have some health checks, which are really for physical health, particularly targeted to those with mental illness. And the fourth thing which I would like to focus on is really to improve the integration aspects. It's not just, when we're talking about mental health, it's not really about mental health, but it's also about education, about the employment, about social services. These links are often not systematic. They are lacking. There is very little communication that exists. There are some countries which have made this as a specific objective of their policies. Austria and the Netherlands are among those, or even Belgium has a quite interesting examples in the program that really brings together the coach, the advisors from the health sector, from the social policy sector, from the employment sectors, so that they work together as a team. And obviously there is the issues of the competencies. It's not just competence for GPs. A teacher which is confronted with a case of mental illness in a student is unable to recognize it and doesn't know how to deal with that. So investing in the skills of those individuals and making sure that there is no discrimination or stigma at any stage of the processes are really quite important and significant goals. Again, there are some interesting examples that can be looked at. In Australia, the business in mind, which really puts a lot of emphasis in what happens in the employment sectors, but also in the United Kingdom. So I will stop at there. I think I highlighted some key facts about how neglected and how severe are issues related to mental illness. There are some good examples out there across countries, although there is a general lack of information. Greece is clearly in a quite difficult situation right now with a severe economic and financial crisis, which will have important effects on the mental health of people and on the mental health structures. So I'm hoping that this conference will help to put mental health much more prominent on the agenda. It's something that needs to be consistently and always increasingly done, because really the only way to address mental health is to make sure that this is considered something that counts. The mental health services, quality of health services is something that counts and make a difference. Thank you very much.